Hi, I am Jenny Moore, and I'm presenting on development and results of an implementation plan for high-intensity gait training. Now, recovery of walking is often a primary goal for patients undergoing stroke rehabilitation, and it's also a primary determinant of daily function and community participation. Now, the evidence indicates that high-intensity gait training improves gait speed, walking distance, balance, aerobic capacity, and more. But high-intensity gait training is often not delivered as part of routine rehabilitation practice. Instead, usual treatment provided for the goal of recovering walking often includes several different interventions at a relatively low dose. In this project, our goal was to shift treatment to prioritize high-intensity gait training so that about 80% of the treatment time was spent providing high-intensity gait training on a treadmill, over ground, or on the stairs, and targeting at least 70% heart rate max. And then the other 20% of the sessions were spent working on family training or collecting outcome measures. Now, this project included two phases. The first phase was usual care. In this phase, we implemented a gait assessment battery that allowed us to determine outcome measurement changes during usual care. In addition to that, we collected stepping data to understand how many steps patients were taking during the day and during physiotherapy sessions. Now, phase 2 included the implementation of high-intensity gait training, and then we monitored fidelity of the intervention. So basically what that means was that we were monitoring to see whether the clinicians were delivering the intervention as recommended. And when they started doing that, we evaluated the effectiveness of the intensive gait training program in comparison to usual care. Now, the practices that we implemented included primary outcome measures of the 10-meter walk test, fast and self-selective velocity, 6-minute walk test, and the Berg balance scale. And we also collected demographics and secondary outcome measures. The intervention we implemented included high-intensity gait training as defined in Halvorsen et al. 2014 in the appendix at a frequency of 4 sessions per week, an intensity of at least 70% heart rate max, with as much time as possible walking in that intensity zone in a 1-hour session. Now, this project was implemented in Oslo, Norway at 2 hospitals that were on one hospital campus. Oslo University Hospital admits about 160 patients with stroke yearly, and they have an average length of stay of 20 days and 5 physical therapists on staff. Oslo Municipality admits about 70 patients with stroke yearly, and their average length of stay is 21 days, and they also have about 5 physical therapists on staff. And then the Regional Center for Knowledge Translation and Rehabilitation was the coordinating center, and we are responsible for proposing, initiating, and coordinating methods and models of quality improvement and knowledge translation and rehabilitation. The inclusion criteria for patients in this project were adults greater than 18 years of age, that they had sustained a stroke within the previous 2 months, they were receiving treatment at a participating facility, and they had a goal to improve walking function. They were excluded if they had a functional ambulation category of 5, which indicated that they were able to ambulate independently on non-level and level surfaces, stairs, and inclines, or if they were medically unstable and not cleared to participate in high-intensity training. Now, we also included clinicians in this project, and the clinicians had to be employed as full or part-time clinicians at a participating facility. Now, we used 2 frameworks to guide this implementation project. The first was the knowledge action cycle, which you can see here on the slide. This cycle guided our implementation plan. And then we used the consolidated framework for implementation research to describe our barriers and facilitators to knowledge use and select, tailor, and implement knowledge translation interventions or implementation strategies. Now, these 2 frameworks together resulted in a multi-component implementation plan that included 26 implementation strategies. Now, these are detailed in a recent publication in Journal of Neurologic Physical Therapy in the appendix. So if you'd like to hear more about it, please take a look at that. Now, we also had several core principles, measures, and outcomes that we used in this project. First, we engaged stakeholders throughout the project. Next, we repeated the knowledge action phases if needed. So if implementation was not going as expected, then we were able to go forward and backward through the action cycle to repeat phases and improve the implementation of high intensity gait training. And we also had the ability to do a few phases at the same time. Our fidelity metrics included steps per day, steps per session, and heart rates achieved during physiotherapy. And we also collected data from clinicians on current practice, beliefs, barriers, and facilitators using surveys that were modified from Swinkles and from Jetty. And then we also used the organizational readiness to implement change to understand the organization's readiness to implement this program. We collected patient and gait and balance outcome measures, which I'll talk about today, but we also collected patient perceptions, and that is reported on in our recent JMPT publication. We also collected lots of data on informal interviews and discussions, and I'll reflect on those some in this presentation, but they're detailed more in our recent publication. The analysis that I'm going to discuss today includes fidelity in patient outcomes and surveys. We use descriptive statistics and unpaired comparisons for baseline measures, stepping, and training data. And for our outcome measures, self-selected velocity, fast velocity, and 6-minute walk test at admission, week 1, and discharge, we used a two-way repeated measures ANOVA with intervention and time as factors. And then we did this again using the 3-week outcomes. So we looked at admission, week 1, and week 3 because we discovered that our implementation phase patients had a longer length of stay. Now for the surveys, we used a Wilcoxon sign rank test to analyze pre to post implementation surveys and post implementation to follow-up surveys. Now here's the timeline for the project. We actually collected data between 2017 and 2018, but as you can see here, we spent a lot of time prior to implementation getting the clinicians ready for implementation. The clinicians actually took quite a bit of time to understand the literature. They met regularly, they met with us regularly, and they came to consensus that this was something that was right for their practice. And so they collectively made a decision to become part of this project. And then after we collected data, we continued to work on our sustainability activities to try to ensure that this was a practice change that would stay in place. Now here are our results for demographics and baseline characteristics. You can see in our usual care phase and our post-implementation phase that in general we didn't have any statistically significant differences except for the length of stay, in which the usual care phase had about 23-day length of stay, and then the implementation phase had about a 35-day length of stay. Our fidelity metrics indicated that we were able to successfully implement high-intensity gait training into clinical practice. We saw a significant increase in steps per day, a significant increase in steps per session, and approximately 34% of the session was spent in the target heart rate zone. The average peak heart rate was approximately 79% heart rate max. Now, the results of our surveys and interviews indicated that this was an organization that was ready for this change. Their organizational readiness to implement change scale was 44.5 out of 60. And then our clinician surveys indicated significant perceived practice changes as well as improved perceptions related to high-intensity gait training. The clinicians reported after implementing high-intensity gait training that they had a greater focus on walking training after implementation. And then in addition to this, they indicated that they felt that high-intensity gait training improved the quality of their treatment. And even with high-intensity gait training only focusing on walking training, they felt that they were able to adequately address transfers and balance as well. And then our 2-year follow-up indicated that the perceptions were maintained. For more information about these survey results, please see our publication in 2021. Now, this shift in practice resulted in a significant impact on gait speed, walking distance, and balance outcomes with high-intensity gait training. On this slide, you can see 4 graphs with change in self-selected velocity, change in fast velocity, change in 6-minute walk test distance, and Berg balance scale. You can also see the blue line here represents usual care and the red line represents post-implementation. There are significant between group differences at week 1, week 3, and at discharge for all 3 gait measures. In addition, you can see all of these measures exceeded what's considered to be clinically meaningful within the first week of high-intensity gait training, but not during usual care. Now, the change in Burke balance scale actually wasn't significantly different until discharge, but we feel like that's a really interesting and good finding. High-intensity gait training does not focus on isolated balance training like we typically do in usual care. Instead, we integrate balance activities into our walking activities. So while we didn't specifically focus on balance in standing and sitting, we were able to see the same kinds of improvements in these functions as we could with usual care, while still getting greater improvements in walking outcomes. Now, another interesting thing to note about these graphs is noted here by the ovals. You can see that we got about as much change in 1 week with high-intensity gait training as we did with the entire length of stay for usual care. So high-intensity gait training was more effective and more efficient than usual care. In summary, this multi-component implementation plan that targeted barriers resulted in successful implementation of high-intensity gait training. The results included improved patient outcomes and clinician perceptions. The contributors to this success may have included the implementation methods that we used, stakeholder engagement, the frameworks that we used, and the fact that we targeted barriers with our implementation strategies. In addition, these clinicians did not report on the surveys that they used traditional techniques such as BOBATH or NDT in their usual care. Instead, they used a lot of different task-specific interventions that didn't necessarily always include walking. So these clinicians simply had to shift their treatment to include more task-specific, high-intensity walking training. So this might have been an easier shift for these clinicians to make. In addition to that, these clinicians were ready for this change. They spent a lot of time discussing high-intensity gait training, understanding its potential impact, and they, as a group, came to consensus that this was right for them. So that may have helped us get this into practice more quickly. Okay, that concludes this presentation. I'd like to quickly acknowledge my many collaborators in this project in the United States and in Norway. And please reach out if you have any questions. Thank you.